Now we'll go phase by phase, and this is where I want you visualizing real patients, which we'll cover more in lab. At initial contact, the knee is near full extension. The tibia is in slight external rotation, setting up the knee for load acceptance. The ground reaction force rises rapidly and passes posterior to the knee, creating a flexion moment. Muscle activity. The quadriceps, the vastus recti over rectus femoris, are already active eccentrically. Hamstrings co-contract to stabilize the tibia and protect the joint. The clinical note is if quadriceps control is poor here, patients often adapt a stiff knee strategy or report instability. Loading response. This is where the knee earns its keep. The knee flexes to 15 to 20 degrees under load. The tibia internally rotates as the foot pronates. The quadriceps hit peak eccentric activation to control knee flexion. Hamstrings decrease activity as load transfers forward. The gastrocnemius begins contributing, helping stabilize the posterior knee. And another clinical note, insufficient quad strength here leads to knee buckling, rapid flexion, or compensatory trunk lean. In mid-stance, the knee begins extending again. The tibia moves forward to neutral rotation. Quadriceps activity drops significantly. The knee is now supported more by skeletal alignment and passive structures. The gastrocnemius provides posterior knee stability as the tibia advances. Another clinical pearl. If you see high quad activity in mid-stance, think pain, instability, or fear. Terminal stance. The knee is near full extension. The ground reaction force moves anterior to the knee, creating an extension moment. The quadriceps are mostly quiet during this phase. The gastrocnemius ramps up, controlling tibial advancement and stabilizing the knee as the ankle dorsiflexes. Clinical note, Weak plantar flexors often show up as excessive knee flexion here. Pre-swing. The knee rapidly flex to about 35 to 40 degrees. This is passive and active. The ground reaction force shifts posteriorly. The gastrocnemius assists with knee flexion. And rectus femoris works eccentrically to control it. An overactive rectus femoris causes stiff knee gait during swing. Initial swing. Knee flexion peaks around 60 degrees. The hamstrings contract concentrically, and gastrocnemius assists with early swing. Clinical note: if someone has weak hamstrings, it usually leads to poor foot clearance. Mid-swing, the knee begins extending. The quadriceps turn on concentrically, and the hamstrings quiet down. Clinical pearl: delayed quad timing here affects terminal swing positioning. Terminal swing. The knee extends to near 0 degrees. The quadriceps hit peak concentric activity, and the hamstrings fire eccentrically to decelerate extension. Clinical note: poor hamstring control leads to hard heel strike or hyperextension.